Predicting which CLL patients respond to Liso-cel CAR-T. Hi, I'm Dr. Brian Kaufman, and I'm going to be reviewing some of the top abstracts that were presented at the European Hematology Association meeting held in Madrid in 2024. Let me start with the bottom line. Liso-cel CAR-T is an effective therapy, but only for a minority of CLL patients. Having lower disease burden, improved response rates, having poor markers turns out not to be a major factor. Who performed this research and where was it presented? Dr. Bill Wierda from the MD Anderson Cancer Center gave the prestigious oral presentation on behalf of his colleagues at the European Hematology Association annual meeting, or EHA 2024 in Madrid. Let me give a little background. Lisocabtagene Maraleucel, or Liso-cel for short, is the only approved CAR-T therapy for CLL patients. Its labeled indication in relapsed refractory CLL is restricted to those who have failed at least 2 prior lines of therapy, including a BTK inhibitor and a BCL2 inhibitor. In this tough-to-treat group, the overall response rate has been less than half, and less than 1 in 5 have had a complete response, or CR, and that's the one that's associated with a lengthy remission. As the therapy can be quite difficult, though the mortality rate is very low, and it's expensive, it would be good to be able to predict who is most and who is least likely to benefit from this therapy. Let's look at the methods and participants next. 87 patients with relapsed refractory CLL or SLL, small lymphocytic lymphoma, from the Transcend CLL 004 clinical trial were studied. This was a post hoc analysis, and it was performed to search for correlations between the likelihood of achieving a complete remission, a CR, a partial remission, a PR, or those two combined is the overall response rate, with specific patient characteristics. So they were said, do these things correlate with specific patient correlations such as demographics, disease state, and biomarkers? What were the results? Of the 87 patients, there were 16 who achieved a complete remission, 25 with a partial remission, 40 with stable or progressive disease, and 6 who could not be evaluated. Lower beta-2 microglobulin, or B2M at screening, was more commonly observed in patients who reached a complete remission. Earlier stage disease, RI stages 0 through 2, at the time of initial screening, was also predictive of achieving a complete remission. Those with smaller lymph nodes showed trends towards achieving a complete remission. Pre-treatment characteristics associated with a higher response of having any kind of response to the therapy, whether it be a complete remission or partial remission, included absence of bulky disease and smaller lymph nodes. What was interesting and important is that there was no correlation between achieving a response, whether it was a complete remission or partial remission, and all the following: age, sex, mutated TP53, deletion of 17p, unmutated immunoglobulin heavy chain variable region, or IGHV, in complex karyotype. In other words, poor prognostic markers were not a factor. So let me go into a little more detail and kind of discuss this. In order to live up to its promise, CAR-T therapy outcomes need to improve beyond the 1 in 5 who now have durable responses. Fortunately, there are several promising paths forward. Combining Liso-cel with other medications to augment and/or complement its activity is one possibility. and the next generation of armed or dual-targeted CAR-Ts are also an exciting development. How to choose the patients that have the best chance to be successful is another method to improve outcomes, and that is what this post hoc analysis offers us. So let's summarize. The great news is that Liso-cel, like the other cellular therapy, the only other cellular therapy used in CLL, SLL, namely allogeneic hematopoietic stem cell transplant or a bone marrow transplant, seems to be completely agnostic to all the traditionally poor prognostic markers. That has not been the case with older chemoimmunotherapies, and to some lesser extent with the newer targeted therapies. The CAR T cells have proven to be good killers of even the toughest CLL cells. It does seem, however, that a greater disease burden, specifically advanced RI stage, bigger nodes, and higher B2M, which reflects more disease activity, is associated with poorer outcomes. This story is similar to that occurs with transplants. There are only so many cells to do all the cancer killing, and those cells can get tired. CAR T therapy is an important element in treating CLL. Studies like this will help us better understand what its best role is. On the website, there is a link to the actual article. Thanks for listening. Stay strong. We are all in this together.